Hello everyone, this is Dr. Ismail and we are from Every Surgeons. Today we are going to study some important clinical science in surgery. So why studying these clinical science are important? Because whenever we are going in the periphery or in the some rural setup where there are no any radiological investigation available, in that place there is clinical dilemma how to diagnose the patient, and knowing these clinical signs are very much important. And also if you have done any kind of radiological investigation, in the bottom of that they have mentioned, radiologist has mentioned that kindly correlate clinically. So knowing the clinical signs are very much important. For example, if a patient comes to your OPD with abdominal pain and you have to advise any kind of ultrasonography of abdomen plus pelvis, and you have to mention specifically that for your radiologist that you have to see the appendix, you have to see any bowel wall thickening, or you have to see any patient with the ovarian torsion or any kind of some specific investigation to patient by your clinical knowledge and your clinical science and your examination finding, so that it will make job of radiologist easy, and also it will give you accurate diagnosis. So that is the important of knowing the clinical science in surgery. So today we are not going to deal all the science in surgery, but we are going to deal today the some of the rarest science which we are coming across today. So first, coming to starting to our first sign is our mallet guy sign. So we know that in the pancreatitis, patient will be having severe epigastric pain which relieves on bending forward and it radiates to the back, and that is called typically called as mammalian bending sign, and we know this sign. But what about this mallet guy sign? In mallet guy sign, in case of acute on chronic pancreatitis or chronic pancreatitis, best way to palpate the pancreas is ask the patient to be in the right lateral decubitus position, flexion of knee joint, flexion of hip joint, and ask the patient to take breathing from the mouth. And you have to palpate the pancreas best from the epigastrium or left hypochondrium. You may ask why only left hypochondrium or epigastrium. This is related to anatomy of the pancreas, because head and body of the pancreas, these are the retroperitoneal structure, and our tail and some part of the body of the pancreas towards tail is our intraperitoneal part of pancreas, which is present on our glenorenal ligaments. So that is why we are going to palpate on the left hypochondrium or epigastrium. On giving the pressure over the left hypochondrium and epigastrium, patient will be having pain or patient is having tenderness. So this is the mallet guy sign. So this is seen specifically in case of acute on chronic pancreatitis or chronic pancreatitis. Also this is the best way to palpate the pancreatic pseudocyst also. So coming to our next sign, this is the Nicholson's maneuver. So what is this Nicholson's maneuver? As you know, in trauma or any kind of bowel pathology, patient is perforated peritonitis, patient will be having rigidity or guarding. So guarding is basically voluntary and rigidity is involuntary rigidity. So patient will be having so much of pain and he is not able to palpate you properly, and you will be having confusion whether it is a rigidity or guarding. So to remove this confusion, there are multiple maneuvers are available. One, you have to speak with the patient and divert his attention so that guarding will go away and you have to feel the organ. And another point is ask the patient to take breathing from the mouth. In that aspect also guarding will, or any kind of voluntary guarding will go away, but rigidity will not go, it will persist. And another maneuver is our Nicholson's maneuver. So what is this Nicholson's maneuver? You have to give pressure over the lower end of the xiphisternum. And why this giving pressure over the lower end of xiphisternum? Because if patient is guarding voluntarily and you are giving compression on the thorax, so it leads to stopping of the thoracic kind of breathing, and patient will start breathing from the abdominal cavity, abdominal wall or through the abdomen, so that if there are any voluntary guarding, it will go away and you can differentiate between voluntary guarding and rigidity. So this is our Nicholson's maneuver. After doing Nicholson's maneuver also still patient is having patient is having very much of guarding or very much of tense abdomen, he is not able to palpate properly the underlying structure, so then you can label it as a proper rigidity, because rigidity is involuntary and guarding is voluntary. So this is our Nicholson's maneuver. So coming to our sign is curvilinear Baumgarten sign, or also called as Canaway sign. So what is this curvilinear Baumgarten sign or Canaway sign? In a case of portal hypertension, there are opening of multiple channels which are closed during embryologically. So in the case of portal hypertension, due to any causes of cirrhosis, patient will be having development of channels at the left para-umbilical vein, and if you auscultate over the Ziffy sternum, you will be hearing the continuous hum. So that is because of opening of your left para-umbilical vein, which is specifically seen in your cases of portal hypertension. So this is our the curvilinear Baumgarten sign. So coming to our next is the signs related to our appendicitis. So there are the multiple signs in appendicitis. Most of the we are knowing that is McBurney's point, that is at the spino-umbilical line at the medial 2/3 and lateral 1/3, where the patient will be having maximum tenderness. That is our McBurney's point. At the McBurney's point, base of appendix is located, not any tip. So that is the constant point for our base of the appendix, and also there is a McBurney's incision at the McBurney's point. As we know this point, there are some any other multiple signs. So one is the Sherin's triangle. So what is this Sherin's triangle? It is a triangle formed superiorly by umbilicus, inferiorly by our pubic symphysis. So superiorly by our umbilicus and inferiorly by pubic symphysis, and it is also formed by our apex is formed by anterosuperior iliac spine. So this is our Sherin's triangle. So in Sherin's triangle, patient will be having hyperesthesia. So how to differentiate between rigidity and hyperesthesia, or any guarding and hyperesthesia? So you have to for any kind of to elicit the tenderness or any kind of hyperesthesia, for tenderness or guarding or rigidity, you have to do the deep palpation. For hyperesthesia, you have to just hold the skin, or you have to just hold the skin with your fingers, or you have to just scrape the skin over the abdominal wall. Patient will be having pain, but for to elicit the tenderness, guarding, rigidity, you have to give some of the pressure, which is not which you should not give to elicit the hyperesthesia. It is just gentle scraping over the skin. Patient is having pain in this Sherin's triangle. So why this Sherin's triangle pain is important? Because it is also one of the important signs to label it as a acute appendicitis. Why there is only pain related to this area? Because there is a parietal peritoneum involvement, and because of parietal peritoneum involvement, there are also parietal peritoneum is also supplied by our sympathetic supply, and same pain supplies from the skin is also supplied from our T7 and T9 nerve roots. So these are the ilioinguinal and iliohypogastric nerve roots. So if there is involvement of parietal peritoneum, and also same if there is involvement of parietal peritoneum which carries the pain sensation from parietal peritoneum by T7 T9, and also skin is also supplied by T7 T9, our central nervous sympathetic system will fail to differentiate between whether it is arising from the viscera or whether it is arising from the our dermatome or skin. So that's why patient will be having hyperesthesia in this region, because of our central nervous system fail to differentiate between whether it is a somatic or visceral kind of pain. So that is our Sherin's triangle. So coming to next sign is Rosing sign. So what is this Rosing sign? As we know, appendix is located in the right iliac fossa. So if you give compression over the right iliac fossa, obviously patient will be having pain. But if you give compression over the left iliac fossa, why? Because in the left iliac fossa there are sigmoid colon, there is a transverse colon, which is most of the time it is dilated because of our digested food particle, and there are multiple there are lots of air present in our sigmoid and transverse colon. So suppose if we give pressure over the sigmoid and transverse colon, that food particles will transmit again from left side of the colon to the cecum, and it irritates the appendix, leading to stretching of appendix or movement of appendix. It leads to the pain in this patient. So Rosing sign is giving compression over the left iliac fossa. It leads to pain in the acute appendicitis. So that is our Rosing sign. So this is our classical McBurney. this is our classical McBurney's point, and this left side of the patient giving compression, that is our Rosing sign. So next one is our Cope-Swartz test. So as we know, the most common position of appendix is our retrocecal. So most common position of appendix is retrocecal, but there are, this is the our cecum. So most common position is our retrocecal position, that is our 11 o'clock position. So there are also position of our pelvic appendix, and there are, this is the IC junction, ilium, this is the retrocecal, this is the pelvic position of the appendix. There are also position of the appendix, that is pre-ileal, and also there are position of post-ileal. So these are the different position of the appendix, but our retrocecal position of the appendix is the most common. And pain on passive extension or active flexion at the hip joint will leads to pain if there is a position of retrocecal appendicitis. So why only on passive extension or active flexion of retrocecal appendix will leads to pain? Because in retrocecal position of appendix will be located on the psoas major muscle. So psoas is the major flexor of our hip joint. As we know, on doing flexion of the hip joint, the appendix which is landed over the psoas major muscle get irritated and it leads to the pain in the patient. That is our Cope-Swartz test. So coming to our next test, that is our obturator test. So this is also one of the important sign. What is this obturator test? And based on that obturator test, why the patient is in the supine position, and you have just asked the patient to flex at the hip joint and ask the patient to do internal rotation of hip joint. This is the action of our obturator muscle. So whenever you are doing muscle internal obturator muscle, so whenever you are doing obturator internal, so whenever you are doing this action, if there is appendix is pelvic position, obturator internus muscle action will leads to irritation of the appendix, because appendix is landed on this obturator internus muscle position in this patient. So based on doing the position of our Cope-Swartz test and also obturator test, we can locate the size of the appendix preoperatively without doing any radiologically. Also you can ask your radiologist friend that my Cope-Swartz test is positive or obturator test is positive, but you are giving some other position of appendix. So you can correlate clinically and also radiologically. So these are the important tests for appendix. And coming to our Boas sign. So what is this Boas sign? So in a case of acute cholecystitis, we know that is a Murphy sign, that is you have to hold your hand in the right subcostal area and ask the patient to take deep breathing. If the patient is having pain, that is Murphy sign. If you elicit in the sitting position, that is Murphy sign. If you elicit in the sitting position, that is your Moynihan's method of doing this point. And also there is a Murphy sign in the patient while doing sonographical, also Murphy sign if there is a pain. So as we know Murphy sign. So what is this Boas sign? So basically this Boas sign is patient with acute cholecystitis. Patient will be having hyperesthesia, as we discussed in the beginning, in the posterior aspect of the 8th and 9th intercostal space on the right side. So why this? Because as I told in the beginning, our gallbladder pain supply is also from our nerve roots such as T7 and T9 nerve roots, which is also supplied at the posterior aspect of our somatic supply is also from the T7 and T9 root of our 8th and 9th intercostal space. Suppose if there is an acute cholecystitis, pain pathway from the gallbladder is also carried by sympathetic fibers of T7 and T9 roots, and also pain sensation of our skin over the back aspect at the right side 8th and 9th space is also supplied by T7 and T9 roots. So it is a central nervous system which fails to differentiate between somatic and visceral pain. So it will lead to hyperesthesia at the right 8th and 9th intercostal space. That is our Boas sign. So coming to our tenule sign. So what is this tenule sign? So basically our umbilicus is in the central position. So how to locate the position of the umbilicus is located central at an equidistance from our xiphisternum at our pubic symphysis. So umbilicus is located midway between our xiphisternum and our pubic symphysis. So in most of the time in thin individual it is located in the central position. Suppose if there are any pelvic pathology, So suppose there are, if any pelvic ovarian tumor or any growth or anything, umbilicus is shifted upwards. Suppose if there is a lots of fluid or any upper abdominal malignancy, it will shift the umbilicus downwards. So this is the tenule sign where because of pelvic pathology appendix is shifted upwards, or because of any epigastrium pathology appendix is shifted downwards. So that is our tenule sign. So there is also one of the important sign, that is a Kehr sign. So what is this Kehr sign? Suppose if there is a patient with a blood trauma abdomen or any kind of blood trauma abdomen or penetrating injury to our any hollow viscous or any kind of only solid organs such as spleen and liver. Suppose if there is any splenic injury that is leading to moderate to gross hemoperitoneum. So in that aspect, if there is a moderate to gross hemoperitoneum, blood will go and irritate our diaphragm, and diaphragm is supplied by mainly the phrenic nerve. As we know, the diaphragm is supplied by phrenic nerve, that is our C3, C4 and C5. So same phrenic nerve also supplied our the dermatome at our shoulder, that is our C3, C4 and C5. So that's why if there is irritation of a diaphragm, the same pain, the same theory as we discussed before, because of irritation of diaphragm is supplied by C3, C4, C5. Same somatic supply is also from the skin, that is C3, C4, C5, mainly C4. The pain from irritation of diaphragm, it is referred to our tip of the shoulder. If there is any subcapsular or splenic hematoma, gross hemoperitoneum on left side, that leads to the pain over the left side of the shoulder joint. So that is our Kehr sign, classically seen in case of any kind of hemoperitoneum. So coming to what are the normal bowel sound, how to label the normal bowel sound. So basically while doing auscultation, you have to auscultate for 2 or 3 different quadrants, and you have to auscultate for minimum 10 minutes. So in minimum 10 minutes when you are going to auscultate, you will be hearing the 3 to 5 normal bowel sounds and different quadrants. So normal bowel sounds are gurgles and click sounds. So after auscultating for 10 minutes, if there are less than 3 vowel sounds, you can label it as a sluggish peristalsis. If there are no vowel sounds after auscultating different quadrants for 10 minutes, then you can do an absent of vowel sound, mostly seen in acute intestinal obstruction or any kind of paralytic ileus at the later stage. But in the initial stages of acute intestinal obstruction, bowel will try to compensate the obstruction by hyperperistalsis or hyperactivity, that is called as borborygmy, where you can hearing the harsh and louder sounds, that is called as borborygmy. So one more important sign is a dance sign. So what is the sign of dance? Sign D dance. So classically it's seen in the intersusception. So suppose if there is any ileopolic intersusception. So suppose if there is a ileopolic intersusception, what happens in ileopolic intersusception? So in ileopolic intersusception, our ileum is gone into our cecum. So ileum is intersuscepted into our cecum. So suppose this is cecum and this is ileum. So ileum is gone inside our cecum, and because of that there is no any bowel loop is palpated at the right iliac fossa. So our right iliac fossa is empty, and you are going to palpate the same intersusception at the xiphisternum or at the epigastrium or right hypochondrium by olive shaped mass. So if you are not able to feel, or your right iliac fossa is empty, but you are going to feel the mass at the epigastrium or your right hypochondrium, that is olive shaped mass with red currant jelly stool, that is a classical sign of our ileocolic intersusception or any kind of intersusception with empty right iliac fossa, that is called as sign D dance. So coming to next sign is our Blumberg sign. So what is this Blumberg sign? So Blumberg sign is basically, it is a sign of parietal peritoneum involvement. So this is also a method of deep palpation. Suppose if there is an acute appendicitis with parietal peritoneum involvement, you have to give compression over the right iliac fossa, and while leaving the compression, you have to remove your hand suddenly. So it will lead to rebound back of your abdomen wall. So while abdomen wall is getting rebounded, along with that parietal peritoneum is also rebounded. In that aspect, patient will be having severe pain, and that is suggestive of your acute appendicitis, and that is your Blumberg sign. It is the rebound tenderness at the right iliac fossa, and basically this is the sign of your appendicitis. So there are some other points those are the surface landmarks. So what is the gastric point? So basically gastric point is our location, is it is located at the midline of the epigastrium, just below the xiphoid process. So if there is any gastric ulcer, if there are any predominant gastric pathology, if you are having any tenderness over this point, you can label it as a gastric ulcer or any kind of gastritis, typically gastric point. And also there is a duodenal point. So what is this duodenal point? So duodenal point is located half inch or 1.25 centimeter to the right of the midline in the transpyloric plane. So friends, how to locate this transpyloric plane? So transpyloric plane is located midway between the suprasternal notch and pubic symphysis. Don't get confused with umbilicus. Umbilicus is located midway between our xiphisternum and pubic symphysis, whereas transpyloric plane is located midway between our suprasternal notch and our pubic symphysis. It corresponds to body of L2 vertebra. So there are many structures or many anatomical structures happening at our transpyloric plane. So you have to go and read about this transpyloric plane. So surface marking of transpyloric plane is also important because this is how we divide the regions of abdomen. That is, those are the 9 regions of abdomen. One horizontal line is crossing at the transpyloric plane and another horizontal line is crossing at the transtubercular plane, and 2 vertical lines are crossing at our midclavicular point. This is how you divide the 9 regions of the abdomen. So this is the classical duodenal point. Here can you elicit the tenderness at the duodenal point in case of duodenitis or duodenal ulcer or any kind of periduodenal inflammation. There is also gallbladder point. Where is the gallbladder point is located? It is located at the junction of your right costal margin and your suppose this is your abdomen and this is your rectus muscle. So it is located at the junction of your right costal margin and your lateral border of your rectus muscle, where your gallbladder is located. So this is the gallbladder point. You can elicit pain in this aspect in the acute cholecystitis or any kind of biliary colic, or you can palpate the gallbladder pathology best in this position, that is just lateral to your lateral border of right rectus muscle and at the junction with the costal margin. So these are the some of the important signs, and we are going to study some more details and some more chapters in the coming sessions. Thank you. Keep studying.